Thank you for allowing me or inviting me to speak. The need for better understanding of the alternatives for healthcare reform is especially acute right now, as states like Oregon, Washington, and others debate next steps as the push accelerates for state-based Universal Healthcare Act. This presentation evaluates the comparative ability of 4 alternatives to solve the major problems of healthcare. Oregon Task Force on Universal Healthcare, on which I served, identified 3 major problems with our current healthcare system: unsustainable cost, unworkable complexity, including the financial anxiety, stress, and worry of the current system that cannot be measured in dollar cost, and inequitable access, including the way we divide people into groups which have very different access to healthcare. Related to the problem of inequitable access is a shortage of providers, particularly in rural, primary, and behavioral areas. Against these major problems, we will evaluate 4 reform alternatives: mandatory purchase of private insurance, such as the ACA attempted, further expansion of Medicaid, public option which competes with private insurance, and a simplified payment structure, sometimes referred to as a single-payer system. A flowchart of the financial system can help demonstrate how the current system works and how reform alternatives would affect the major problems. This flowchart may look complex, but it's actually very simplified to show only the major components. We will look at this flowchart in more detail after we start with a look at the history of how we got here. First, a little definition. We could label the box on the left patients, but since all residents are potential patients, it is labeled residents. On the other side, professional medical providers, defined as any person, facility, organization which provides diagnosis or treatment, including physicians, specialists, therapists, nurses, hospitals, clinics, technicians, and pharmacists. As little as a century ago, virtually all professional medical care was accomplished by a direct financial exchange between each patient and each provider. Adding one more level of complexity, charitable philanthropy has always played some role in healthcare. There are 2 types of this philanthropy: donations of money and voluntary donations of unpaid time. 100 years ago, and for that matter, since the beginning of time, most care was provided at home by family members or close friends. The first hospitals, many of them started by religious volunteers, were founded to provide care to people who had no family to care for them. Family and volunteer care still exists at some level, but since this flowchart only measures the financial impacts, it will only show private cash donations to pay for the care of others, or donations which are made to build facilities or purchase major equipment. Here is an estimate that, here is an estimate that 100 years ago, about 98% of healthcare was purchased directly from providers. About 2% was paid for by charitable donations. Looking ahead at private donations over the years, private donations reached a peak in the 1980s as a percentage of total healthcare and have stayed in that range of 4 to 6% of all healthcare costs. In any financial system, there will always be some losses due to overheads. Up until 1940s, medical financial overhead was probably about 3%, if nothing else consisted of the doctor having to keep track of payments, going to the bank to deposit checks and cash from patients. In thinking of overhead, is useful to think that for every dollar of actual healthcare needed, residents would need to spend $1.03, since they also needed to cover the overhead. As we shall see, overhead has been going up in the last century. By 1950, most professional care was still provided by direct financial transactions, probably about 85% between the patient and provider, but the use of the middleman was growing. State and county level programs, including some temporary assistance for people without income, was coming into play. Major medical insurance, similar to fire insurance on a home, was for rare but expensive events. With the rise of middlemen, overhead doubled from about 3% to about 6%. Through the 1950s, 60s, and 70s, reliance on middlemen increased significantly as direct payments fell to less than 1/4 of total cost. Employer-sponsored medical insurance continued taking a larger role in between the patient and medical providers. Employers got involved because of IRS rulings that allowed employees to receive health insurance benefits tax-free when arranged through an employer. Insurance gradually became regarded as a convenient way, if a more expensive way, to pay for smaller medical bills rather than just for major care. The federal government, which had almost no role prior to 1960, began assessing taxes to pay for Medicare, Medicaid programs, which grew quickly to cover over 1/3 of all cost. Private donations had doubled to about 4%. And for providers, the proliferation of different insurance policies and public programs required a major increase in billing staff. In this time period, total overhead had doubled again to about 12%. Jumping from 1980 to 2019, we see the continued decline of direct payment down to just over 10%, continued rise of middlemen in the form of federal, state, local governments, and private insurance. In reading this flowchart, the percentages on the right side of the flowchart are how providers get paid, mostly by middlemen. For instance, 32% of all provider revenue comes from private insurance plans, 22% comes from Medicare, about 17% comes from Medicaid, rest comes from other sources. The percentages on the left side are how residents pay for healthcare, mostly payments to middlemen. Larger payments are through federal general fund taxes and through employer-based plans. Private donation still exists and is shown on the bottom arrow. Private donations are still in the same proportion as 1980. Direct payments have fallen from the majority of all payments in 1950 to just 11.3% currently. About 4% of this is co-pays, deductibles, co-insurance. The rest is to cover services which are not insured. For example, about half of dental and optical customers choose to pay cash, and most durable and non-durable supplies are purchased without insurance. Here is the 60-year trend line for direct payment, also known as out-of-payment cost. Note that although out-of-payment costs may still be increasing as a dollar amount, continues to decline as a percentage of overall healthcare cost.
Did you mean out of pocket?
Yes, whatever I said, I meant out of pocket. Private insurance consists of both regular health insurance and the medical portion of liability insurers such as workman's comp, auto insurance, home insurance, medical liability insurance. Private insurance accounts for 32.2% of total payments to providers, with workers' compensation adding 1.3%, auto, home, the medical portion of auto, home, and other liability adding another 1%. Medicaid CCOs, such as operate in Oregon, are specialized private insurance companies covering about 16.7% of all costs, are actually higher in states like Oregon, lower in states that did not do the Medicaid expansion. Looking at how residents currently pay for private health insurance, employer-sponsored plans count for 29.8% of payments paid through workers foregoing wages in favor of medical benefits. Private individual policies shown account for 2.4%, include purchase of Medigap and marketplace policies subsidized by the federal government. Looking at government programs, Medicare, Medicaid are well known and account for most purchases of healthcare through government. Medicaid accounts for about 22% of all healthcare payments to providers, but note that Medicare payroll taxes and premiums on the left side only cover about the 11% of the cost, meaning that Medicare is highly dependent on the general fund. It's only about half funded. Remaining half of Medicare, all of Medicaid and other programs are paid out of general fund dollars, which are the obligation of general taxpayers. For Oregonians, federal income tax dollars amount to 27% of all payment, and state income taxes add another 9.9% for a total of 37% of all medical funding. There are many small federal and state programs and grants that are shown here just as other programs. In the upper right corner is direct care, mostly funded through government programs. About 4.3% of all care is provided directly to specific eligible residents by the VA, Indian Health Service, public health programs, through other direct care provided by correctional facilities, schools, universities, and workplaces. Because this care efficiently serves very specific populations, these services are expected to stay operating as they do now, even under a universal care system. Here are the major trends since 1960 in who pays providers. While direct pay out-of-pocket payments have declined, private insurance, Medicare, Medicaid have increased. In the last 50 years, Medicare payments have risen from about 10% to 22%. Medicaid payments have risen from 6% to 18%. Private insurance has leveled off due to a number of factors, including the shift to a gig economy. COVID pandemic created a blip in everything. As you might have guessed, total system overhead has doubled again to about 25%. Meaning that on average, we must pay $125 to receive $100 of medical care, $125,000 in order to purchase $100,000 of medical care. This flow chart relies heavily on the Oregon Task Force actuarial report to show the location of overhead. And just to give a few examples, billing overhead is assumed to be about 20%, but it only covers about 80% of all transactions. So that means about 16% of the overhead is actually in provider billing departments. Looking at private health insurance, according to the National Health Expenditure accounts, the overhead average is about 12%, but because that only covers 1/3 of all healthcare costs, the overhead there adds up to 4%. Looking at liability insurance, overhead on individual policy is closer to 60%, but because that covers a fairly small percentage of all healthcare dollars, adds up to about 1%. Government programs generally have lower overhead. There is more to the story, just not just looking at cost, but moving on to equitable access. Used to be that medical care costs the same no matter who you were. Beginning a few decades ago, we've gradually split healthcare into a quasi-caste system where medical providers get paid a different amount depending on who the patient is. Using Oregon Task Force actuarial data, Medicaid in Oregon now pays just 69 cents on an average cost of $1 of care. Medicare pays 81 cents. Private insurance has gradually risen to $1.37 to make up the difference in declining Medicare and Medicaid reimbursements. Restricting reimbursements for Medicare and Medicaid to below their average cost of delivery has been like stepping on one end of a hot water bottle. You can make it go down on one end, but it goes up on the other. These different reimbursement rates are shown here in the provider box. Providers who see too many Medicaid and Medicare patients cannot cover their costs of staying open. So most providers limit the number of Medicare and Medicaid patients they will accept, and some refuse to see these patients at all. Another source of chronic inequity comes in through the tie between healthcare and employment, since many disadvantaged populations have less access to the kinds of jobs that offer medical benefits. Now, getting back to the comparison of 4 alternatives against the problems of high cost, complexity, and inequitable access. Mandatory private insurance, such as was suggested in ACA, anyone not on Medicare, Medicaid, or employee insurance would have to buy private insurance. Forcing uninsured or underinsured individuals into mandatory private insurance may give a few people better access to health care at a higher cost, and because more people will pay at the $1.37 rate, would not do anything to address the major existing problems of cost, complexity, or other access inequities. Many state-level programs, including in Oregon, are based on expanding Medicaid. Further expansion of Medicaid has several effects. Presumably, income tax, particularly federal income taxes, will need to rise to meet the increased federal obligation. Because Medicaid only pays 69 cents on the dollar, any increase in the number of patients eligible for care at significantly below provider cost is likely to compound the problem of providers refusing to serve Medicaid patients, and in fact is likely to generally aggravate the supply of providers. Overhead drops a little because Medicaid programs have lower overhead. But another problem with continuing to rise the percentage of people who are eligible for free care is depicted in this graph of healthcare costs by income. 1950, healthcare could be paid equally by almost everyone at standard prices. By 1970, 20% were eligible for subsidy. Currently, about 1 in 3 qualify for some kind of subsidy. Plan proposed in Oregon involved half paying little or nothing for their health care. How far can we expect to go in this direction? The graph shows the importance working on an economy where everyone participates through jobs which allow them to thrive, and at healthcare which is financially sustainable and affordable. This graph demonstrates how Oregon taxpayers earning above $100,100 currently paying for over half of all healthcare, principally through their federal and state income tax dollars. Public options, where a public insurance company competes with private insurance, is a popular idea among legislators because you don't have to say no to anyone. But a public option actually adds to system complexity by increasing the number of system components while eliminating none. In 2021, healthcare financing report by the Colorado School of Public Health estimated that continuing a multi-payer system with the addition of new public option would increase complexity and add 2 to 3% to the total cost of healthcare, raising today's overhead from about 25% to about 28%. Any program configured as an optional Medicaid buy-in actually contribute to the problem by finding the problem of finding providers willing to see patients at below actual cost of providing services. Dozens of public options, including co-ops operating as a public option, have been tried. All have failed. The reasons are that potential savings of a public insurance company are overestimated. Public options have attracted very few customers, but the real killer, unequal distribution of high claims patients, which dooms premium rates. In 2017, the top 1% of claims averaged $236,000, highest individual claims well into the millions. It takes about 400 people with almost no claims to equal one big claim. For insurance carriers, it almost doesn't matter what they charge in premiums if they are careful who they attract and who they repel. Consider for simplification that the bottom 80% of the population averages $2,400 in medical claims per year. The top 20% averages $44,000. When private insurers compete with a public option, all they need to do is shed 3% of their high-cost patients onto the public option to lower their cost by 10%, raise the public option cost by 10%. As the healthier people flock to the lower private premiums, concentrating more of the high-cost patients in the public option, the public option's premiums always spiral up to the point of no return. Private insurance companies can shed expensive patients in a way that a public option cannot or would not. Finally, we come to the alternative of a simplified payment structure or a single payer. In this structure, all existing payment components would be replaced with one common payment structure. Simplified payment structure, such as a single payer, would address the major problems of cost, complexity, and inequity. Total costs would be reduced by a minimum of 12 to 16% by reducing overhead. The complexity of billing would largely be eliminated. Major causes of inequity would be eliminated because providers would be paid $1 on the dollar of cost of care, regardless of who they see, because obtaining healthcare would no longer be linked to employment. Healthcare assessment would replace premiums and other private expenditures. Compared with the other alternatives, single payer model offers a path forward for future generations, which none of the alternatives can come close to. And any board or commission charged with addressing universal care truly needs to give priority consideration to single payer or simplified payment type systems. Anyone who wants a copy of my slides can email me at george@peak.org. So thank you very much. And I think I'm right about on time. Back to you, Mike.
Thanks, Warren. There's cheers going up in the screens here. Thank you so much for that. Do you have any questions? A lot of applause here. Sam Metz from Portland.
Thank you, Warren. That was your usual brilliant presentation. One of your last slides used a term called healthcare assessment as funding, a major funder for single payer. Is there another term that can help us understand what that is?
Tax. Well, you can look at it as a tax. Other countries don't always call it a tax. I mean, it is an assessment based on income or other factors of ability to pay. I think Canadians sometimes use the word assessment for some of their costs, and other countries the same. I mean, basically, it is a replacement for premiums and other private money that goes into healthcare. Thanks, Sam. You made me say it.
Julie,
And presumably,
Yeah.
I mean, there's significant savings available, as I pointed out, and the savings can be used to, when Oregon looked at universal care, they wanted to use more than half of the savings to improve care for behavioral, rural, and primary care.
Julie,
I just wanted to say thank you, and I'm gonna send a copy of your slides along with a comment to Maine's newly created Office of Affordable Healthcare, whose mission is to explore and potentially establish a public option, which you've spelled out the problems with that so clearly with your presentation. So thank you.
Thank you.
anyone else? So as you'll get a copy of this video. Oh, Barbara's waving her hand. Okay, Barbara.
I want a private tutorial, please. I couldn't follow. I mean, in principle, I could follow it, but I couldn't follow as you were going along, even though you had a very measured delivery that would help us to do that. But I just needed a little bit more finger tracing, you know, oh, this is the line I'm talking about now. This is where this comes from. This 4% is really whatever. Okay. So, and like, for example, all those red boxes that were the waste, right? Is that what I remember? That there were red boxes for waste? That was a percent of what? The percent of the waste or the percent of the expenditure? See, that's the kind of question that.
Okay, and that's the percentage of total healthcare cost.
Total of healthcare cost. Okay, that's a help.
And thank you, Barbara. You can write for your certificate of mastery for having sat through the and through a master's level thesis in less than 25 minutes.
So one substitution for that would be to get it to Warren's slides and then watch the video again and stop it when you need to, speed it up when you need to.
Yes, thank you, OPS, for giving me that opportunity.